This webinar today is specifically designed to give my clients, which are the clients of Gold Star Medical Business Services, and our billing representatives, an update on a new article that has come out on chiropractic care for low back pain. The reason why I'm giving this webinar is because there are some new updates within this article that are important for our clients to know with respect to the case management of their established and new patients. Also, there is a wealth of information in this article on the case management of chronic patients, which has always been a difficult topic to talk about and to really get a handle on. So what we're going to do today is we're going to have a number of, let's see, I just need to advance my slide. Here we go. So we have the overview of the webinar today. We're going to talk about the CCGPP and its role in the chiropractic industry. We're going to talk about the details and the summary, a brief summary of the article itself, and what the article means to you and to chiropractors and to billers within the chiropractic profession. We're going to talk about case management of acute low back pain and case management of chronic low back pain. And then we're going to talk about how these guidelines can help you actually build and grow your practice. Sometimes it seems like we're just being regulated to death, and we have such a hard time deciphering how these regulations and these guidelines can actually help us grow. It just seems like it is constantly putting more and more of a burden on us rather than freeing us up to do the things that we do best as doctors. So we're going to talk about that. The other thing we're going to talk about at the end is hopefully have a discussion forum, and I will welcome comments from both the chiropractors that are on this call and the billers that are on the call as well. And hopefully we can have a nice discussion about any questions you may have with respect to this presentation. So let's get right into it. I want to talk to you just a little bit about the Council on Chiropractic Guidelines and Practice Parameters, or the CCGPP. The CCGPP was formed about 20 years ago now at the behest of the Congress of Chiropractic State Associations. And they have received over the years assistance from many different chiropractic organizations, including the ACA, the Association of Chiropractic Colleges, the Council on Chiropractic Education, the Federation of Chiropractic Licensing Boards, the FCER, the ICA, National Association of Chiropractic Attorneys, and the National Institute for Chiropractic Research. So the Council on Chiropractic Guidelines and Practice Parameters has become somewhat of a clearinghouse for articles and position papers within the chiropractic profession to give both chiropractors, insurance carriers, and billing representatives or billing companies, billing departments, guidelines on the treatment parameters that they ought to be employing with respect to their patients. Their mission is to provide consistent and widely adopted chiropractic practice information and to perpetually distribute and update this data as necessary. So they are constantly looking at the guidelines and looking at updates and revisions to these guidelines so that they don't get stale and they keep up with the latest research and with the latest information that is present to us at any given time in our period. Consumers and others can have reliable information on which to base informed healthcare decisions. So actually these papers are available for the general public to read, and actually if you read these position papers, with the exception of some technical aspects of it, a layperson such as myself, a biller, or even a patient could read these articles and have a very clear picture of what the standards of practice are within the chiropractic profession for a variety of different conditions. The CCGPP was also delegated to examine all existing guidelines, parameters, protocols, and best practices. And we're going to use the terminology best practice a lot during this presentation in the United States and other nations with a chiropractic lens. In other words, we have notoriously, as a profession, been scrutinized by the standards of the medical profession, which is in many, many ways unfair, because even the word subluxation in the medical profession has a different connotation and a different definition than a chiropractic subluxation. So what the CCGPP has attempted to do is bring in people from the medical profession to help them gain a better understanding, form panels that include chiropractors, which would be the majority of the panels that write and revise these papers, but also include the medical profession to give legitimacy and to the physician papers that are being written. The participation within these panels and the processes have been very transparent, and a major goal is to represent a diverse cross-section of the profession on the projects that the CCGPP has been involved in. They also have been charged with developing guidelines regarding the most common conditions treated by chiropractic physicians. And we know that condition-based care is very consistent with that found throughout the healthcare industry today. And that's the focus of the CCGPP's effort. They're wanting to bring chiropractic more in line with the rest of the medical profession, because in the past we have been sort of looked at as outliers versus integral parts of the healthcare management of a patient. Now, there's a wealth of information on the various conditions that the CCGPP has written papers on, and they have their own website, which is www.ccgpp.org. And all of the literature that is written as far as physician papers, policy papers, and research that is conducted by the CCGPP in conjunction with their panels are published in the JMPT, which is the Journal of Manipulative and Physical Therapies, and submitted for inclusion in the National Guideline Clearinghouse at guideline.gov. So these articles hold a lot of weight in both the chiropractic profession and the insurance industry as they are looking at standards of care and best practice standards for the chiropractic profession. Today, we're going to be focusing on one of the articles that has been written and published in the JMPT, and that is on the treatment of low back pain, because there has been a new revision as of January 16th of 2016. So we're going to focus on that article today during our webinar. Let's talk about the article itself, and what you're going to see in these next few slides. And if you received my email reminder today, there should be handouts for you that represent all of the slides that are in this presentation. So you should be able to follow along pretty easily. I also emailed you an entire abstract of the JMPT article, so you could read the whole thing if you want to. But what I've done today is I've just taken excerpts, snapshots of excerpts from the JMPT article, and we're going to discuss some of the highlights of this article, okay? So on an overview of the article, the updates to this article combine 3 previous guidelines by the CCGPP that were published between 2009 and 2014. The panel that did this research and combined these updates and updated the information is called the Delphi panel. It was made up of 37 panelists, of which 33 were doctors of chiropractic. 2 of the panelists were instructors at Logan College, and so there were not only active, of the 33, the majority of these chiropractors are in active practice, but there were also researchers and instructors from some of the chiropractic colleges. Also represented within the panelists was a medical doctor, an MD acupuncturist, a PT, and a massage therapist. So they had they had a good cross-section of the medical profession represented within this Delphi panel. The overall conclusion, and as we know, and we have always known this, is that the evidence within this research paper clearly supports that doctors of chiropractic are well suited to diagnose, treat, co-manage, and manage the treatment of patients with low back disorders. And so that's the good news. Nothing has changed in that respect. Okay, so we know that of all of the medical professions, the chiropractic profession is probably the most well suited to the treatment and management and co-management of patients with low back pain disorders. Now, many of you who have been in practice for a long time remember the old Mercy Conference guidelines. And unfortunately, what I have seen over the years is that there are many chiropractors, especially ones that have been in practice for more than 20 years, who have gotten themselves stuck in the Mercy Conference guidelines. The Mercy Conference guidelines were established in 1993 and were really the first formal guideline for treatment parameters within the chiropractic profession. And at the time, it provided very valuable information to both doctors of chiropractic and insurance carriers, including Medicare, with treatment guidelines. But what they did was they based these treatment guidelines on specific numbers of visits for uncomplicated low back pain. And nowadays, unfortunately, what I still hear as a biller is a lot of my clients and a lot of and of course, I was a practice consultant for many years, and I was in practice management. I know what we did. We used to tell our clients if it's an uncomplicated low back pain, you schedule them for 18 visits. And a lot of doctors still do that. They'll still say, well, I was told that I should just schedule 18 visits for a low back problem. And the problem with that is that that's not really considered case management. It's based on visits instead of science. And so what we are trying to do with the articles that are being presented by the CCGPP is to give doctors of chiropractic guidelines that give you treatment windows instead of specific numbers of visits. And so, and there are still practice management companies out there, and I know because I have clients who talk to me about this, who will often give their clients numbers of visits or numbers of treatments to pre-schedule with patients. The more traditional approach I hear is 18 to 24 visits, or maybe it's 12 visits and then reevaluate. And some practice management companies out there are recommending up to year-long treatment plans, which is crazy. The problem with this is that none of this is based on science. It's just numbers. And so what's happening is that doctors of chiropractic take those numbers, plug them into their little formulas, and then use the same formula on every patient. And what is happening is that we, as a profession, are notoriously falling short of proving and documenting these parameters through scientific means. And the thing is that insurance carriers are guilty of it as well. They will basically say to you or to a patient, you are allowed so many visits per calendar year. But if you ever sat with an insurance carrier and got on the phone with them, one of the first things that they're going to tell you is they're going to tell you that number one, a quote of benefits is not guaranteed. We all know that, but we also will hear them say all the time that any visits that are being authorized are based on what they call medical necessity. And so very, very often what you're going to get from an insurance carrier is a visit limitation that would be based on what they would consider acute care treatment, and which would be anywhere from 12 to 20 visits. Now, there are some insurance carriers that don't do that. They say, when we verify benefits, we'll ask them, are there visit limitations? And they'll say, no, it's based on medical necessity. Well, what constitutes medical necessity? And I think we have to be very, very careful that we don't fall onto the very simplified Mercy Conference guidelines that were published 20 years ago, and ignore the research that is being done now with best practice and with evidence-based practices. And so we have to really, really watch out for pigeonholing our patients and our treatment plans into these nice little formulas that may or may not be appropriate for your particular patient. Just because a patient has so many visits under their plan, number one, it doesn't mean that they should be treated for the maximum amount of visits, okay? And insurance carriers, including Medicare, clearly state that, okay? But also, it doesn't mean that they should be cut off from treatment when their visits expire. You as a doctor have to be aware enough of your guidelines, of the treatment parameters, and of the clinical expertise you have in deciding what a patient actually needs based on their clinical findings, your clinical findings, not based on what an insurance company is telling you is the right or wrong or maximum amount or minimum amount of visits they can get. And not only do you have to do that, but you have to clearly be able to explain this to your patients. We're going to talk about what is referred to as the best practice approach. The traditional, and again, I'm taking excerpts now directly from this article that was published in the JMPT. The traditional chiropractic approach, and I quote, in which a trial of natural and less invasive methods precedes aggressive therapies has gained credibility. However, the chiropractic profession can gain wider acceptance in the role as the first point of contact healthcare provider to patients with low back disorders, particularly within integrated healthcare delivery systems, by embracing the scientific approach integral to evidence-based healthcare. Okay? And then going on, it says, by today's standards, it is the responsibility of a healthcare profession to use scientific methods to conduct research and critically evaluate the evidence base for clinical methods used. This scientific approach helps to ensure that best practices are emphasized. Okay, so again, the buzzword today is going to be best practices, and not just, what are my limits, or what can I get, or what can I, how many visits can I get from this insurance plan? I really, really want our clients to get away from that, because again, I feel as Obamacare and as the insurance industry in general is shrinking chiropractic benefits more and more, you as a profession are going to have to basically grow a pair and really be able to have the meat to explain to your patients why just because their insurance carrier allows 12 visits, they're going to need more than that. And so, I want to make sure that you all are empowered to do that today. One of the tables, which is a great table for you to have, and again, remember, this is dealing with basically low back pain, what is the word I'm trying to think of? I just lost it. Anyway, non-complicated low back pain. They have different stages listed. So you have what are called the acute and subacute stages, a recurrence or a flare-up, a chronic patient, and an exacerbation. And Medicare has very, very clear definitions of acute, reoccurrence, chronic, and exacerbation. For acute and subacute stages, what the CCGPP recommends is up to 12 visits per trial of care. Okay, and the treatment parameters they're giving you is 2 to 3 times per week for 2 to 4 weeks. So they're not saying 3 times a week for 4 weeks or 3 times a week for 3 weeks. This is up to you based on the patient's presenting symptoms and how they are responding to treatment. And your reevaluation per trial should be at a 2 to 4 week period and no more than 4 weeks. Medicare requires us to re-examine our patients every 4 weeks in order to be compliant with Medicare rules and guidelines. For a recurrence or a flare-up of a previously treated condition, that would be 1 to 3 times weekly for 1 to 2 weeks. So we call those a mini treatment plan, or a micro plan that would take place if a patient hasn't been seen in a while. And I believe Medicare defines that as more than 35 days. And if the patient comes back and they have reached MMI, but now they come back and they have had a flare-up of the same condition, they would be treated at that point 1 to 3 times per week for a couple of weeks, 1 to 2 weeks, and then moved back into supportive care. For the patient who is chronic, and they need to be scheduled for ongoing care for management of chronic pain, that additional care has to be supported with evidence of either functional improvement or functional optimization. Now, some of these presentations would include, but again are not limited to, substantial symptom reoccurrences following treatment withdrawal, minimization control of pain, maintenance of function and ability to perform common ADLs or activities of daily living, and minimization of dependence on therapeutic interventions with greater risk of adverse effect, And also chronic care would be appropriate if it maintains or improves the capacity for that patient to perform work. And always, efforts towards self-care recommendations should be documented. And we're going to go a little bit more into the whole chronic care scenario a little bit later in the presentation. An exacerbation can be an exacerbation of a chronic condition, or it can be an exacerbation that takes place within a treatment plan. So, very often you may have a patient who is on a trial of care for an acute condition, and that condition is resolving very nicely, but then they go out, they work in the yard. During that treatment plan, they come back and now their symptoms are elevated again. Their pain levels are elevated. Their function is diminished. And so that would be considered also an exacerbation, To schedule a patient for ongoing care for management of chronic pain, that would be anywhere from 1 to 4 visits per month. But take a look at the reevaluation schedule. I'm just going to take off my halo, and I would hope that everybody who's listening would take off their halos as well, and really look at your statistics from the standpoint of how often you perform reevaluations on your patient. I personally feel within the chiropractic profession that this is extremely underutilized. Even within my clients, I see that they do not perform re-exams nearly as often as they should be based on the treatment parameters that are being outlined within these guidelines. And so that is definitely something that you would want to look at as far as if you were ever called on the carpet to prove your work and to prove the science behind your work. Part of that would be how often are you examining and re-examining the diagnosis that you are given to your patients. Another best practice is the documentation of exam. Now, we could do a whole class on E&M coding, and I'm actually going to present another webinar on Friday, April 8th that will be designed just for E&M coding, And so I'll have a webinar invite out to you within the next week or so. But just kind of, if you want to put it on your schedule and if you feel weak on E&M coding, You know, if you're going to employ the best practices within the guidelines that are being set forth right now, that is going to include routine exams and re-exams of your patients. You need to know what that consists of. But in a nutshell, your examination procedure includes a thorough history and evidence-informed examination procedures. These are critical components of chiropractic clinical management. These procedures provide the clinical rationale for appropriate diagnosis and subsequent treatment plans. Assessments should include, but are not limited to, the following: would be your health history, okay, pain characteristics, red flags, review of symptoms, risk factors for chronicity, specific causes of low back pain, examination, and diagnostic testing for red flags, okay? So within your examination procedures, you know, it's not just going into the exam room and doing a little bit of motion palpation and having a few tests. There needs to be a more thorough and systematic method for examining your patients. Remember that the exam is only one part of a number of elements of an E&M code and a properly documented encounter. And what I'm talking about as far as an E&M code would be what we call in chiropractic your new patient exams and your established patient re-exams. And those would be codes 99201 through 99204. And I do not recommend that a chiropractor would ever, I would say it would be more than rare to code a 205, and 99212 through 99214. Okay, those are as far as the standards. These would be the levels that you would typically see a chiropractor perform. And remember, within an E&M code, you have what are called your key components, which represent the history, and within the history there are a number of components to the history, like the chief complaint, the review of systems, etc., personal, family, social history, and so on. And then you have your examination, and then MDM, which stands for medical decision making. In a new patient, just to give you a very, very brief overview, for a new patient exam, you have to have all three elements of these key components represented in order to adequately prove that you have completed a new patient exam on your patient. For an established patient, you have to have two of the three key components. And then also you have what are called the contributing or contributory factors, which represent your counseling, your coordination of care, the nature of the presenting problem, and time. All right. Now again, I'm going to do a full E&M coding and documentation webinar on April 8th at 12 noon. It's going to be on a Friday. And so I hope you can make it, and I will send you an invitation, and I'll send you the handouts for that class as well. I often have my clients ask me about X-ray, and I'm actually seeing a move away from this, which is good. Where it used to be a chiropractor would have a patient come in with low back pain and immediately X-ray them. According to the CCGPP, this is not appropriate. Routine imaging or other diagnostic tests are considered not recommended for patients with non-specific low back pain. Imaging and other diagnostic tests are indicated in the presence of severe and or progressive neurological deficits, or if the history and physical exam cause suspicion of a serious underlying pathology such as tumor, aneurysm, etc. Okay, so if you're listening to this and you take a patient in, a new patient, for example, you do a consultation on that patient, and that patient tells you they have low back pain, and you send them in the back and immediately do an X-ray on them, and then after you X-ray, you do the exam, you've got it backwards. You need to be doing your history and your examination first, and then, if warranted, if you feel that within the history, within the physical exam, you have a suspicion of a serious underlying pathology, you would then at that point take X-ray of the low back on that patient. Patients with persistent low back pain accompanied by signs or symptoms of radiculopathy or spinal stenosis should be evaluated preferably, now they're saying, with MRI or CT. Well, obviously we do not have that. And I am seeing occasionally insurance carriers denying low back X-ray on claims because the diagnosis code does not support the indication of the necessity for that X-ray based on these CCGPP guidelines. And also, what I'm seeing some carriers do is deny the X-ray, stating that X-ray is not appropriate. The patient should have been referred for CT or MRI. If for instance, you do have a diagnosis of spinal stenosis or radiculopathy. So this is something to be aware of, okay? Imaging studies should be considered when patients fail to improve following a reasonable course of conservative care. So what they're saying here is it is appropriate if you have a patient with non-specific low back pain and you have them on a trial of care and they are not improving, at that point you may decide that an indication of X-ray would be warranted, but you would need to document that, okay? Other anatomical, if there is suspicion of underlying anatomical anomalies such as spondylolisthesis, moderate severe spondylosis, post-trauma with worsening symptomology, et cetera, et cetera. So you just have to really evaluate if you are routinely performing X-rays on your low back patients. You may want to reevaluate that based on these new guidelines. The rest of that would be evidence of persistent or an increasing neurological compromise or other factors which might alter the treatment approach. Lateral view flexion extension studies may be warranted to assess for mechanical instability due to excessive intervertebral translation and or wedging. Imaging studies should be considered only after careful review and correlation of the history and examination. Okay? And I've actually seen, I've been doing chart reviews on many of you, as you know, and within these chart reviews on the new patient exam and X-ray, I'm seeing wording such as patient was, upon consultation, patient was sent back for X-ray and then was examined. Ooh, that's bad, bad news. You don't want, you definitely don't want to do that. Obviously, you would want to do your history, your examination, and your X-ray at the end, okay? And don't just send them in for an X-ray just because it's what you normally do and what you've always done. Just be careful about that. So, what are we really dealing with here with low back pain? We're looking at the different types of conditions, the severity and duration. Conditions of illness and injury are typically classified by severity and or duration. And your documentation needs to be rich in this, okay, in this type of wording, severity and duration. Common descriptions of stages of illness and injury are acute, subacute, chronic, and recurrent, and then further subdivided into mild, moderate, and severe. Acute would be symptoms persisting for with a sudden onset and persisting for less than 6 weeks. Subacute would be symptoms that persist between 6 and 12 weeks. Chronic would be symptoms persisting for at least 12 weeks duration and more. And then a recurrent flare-up would be a return of symptoms perceived to be similar to those of the original injury or the original condition at sporadic intervals or as a result of exacerbating factors. And we talked about exacerbating factors being something like overuse. The patient goes and works in the yard, goes out and plays 36 holes of golf, and then just really has a low back flare up from that. Okay, and so these are the different types of conditions that you need to be looking at as far as your documentation goes, and documenting where that patient is within the treatment parameters that you've set for them. Recommended Therapeutic trial will range and are representative of typical care parameters. A typical initial therapeutic trial of chiropractic care consists of 6 to 12 visits over a 2 to 4 week period, with the doctor monitoring the patient's progress with each visit to ensure that acceptable clinical gains are realized. And that takes us back to that table that I showed you earlier in the presentation, which you should have a copy of within the article and within the handouts that I've given you. So if you'd like to, as we're doing this presentation, if you'd like to have that table in front of you to refer back to, that would be a good thing to do. For acute conditions, fewer treatments may actually be necessary to observe a therapeutic effect. I mean, we talk about this all the time to our patients. You know, pain is the last thing to show up and the first thing to go away. And some chiropractors, you know, will say, you know, I'm really good at what I do. I'll treat a patient 2 or 3 times and they're out of pain. And that is in line with how acute symptoms present themselves within low back cases. Chiropractic management is also recommended for various chronic low back conditions where repeated episodes or acute exacerbations are experienced by the patient. It seems as if as you wean them off of care, they can't go more than a certain period of time before they are losing function, before their ADLs are affected, before their pain levels are increased. And particularly when a previous course of care has demonstrated clinical effectiveness and reduced the long-term use of medication. That is a great piece to put in your documentation, is to discuss with your patients what kind of medications they were on before they began chiropractic care for their chronic condition and how the ongoing management of that chronic condition has kept them off those medications. Because I can guarantee you the insurance carriers pay out a whole lot more on some of these medications than they do on chiropractic care for, chronic treatment of chiropractic care. Plus, it's much safer for the patient. You know, putting the insurance company aside, this is a better way for a patient to manage their pain levels, their function, and their care than just being drugged for the rest of their life. Okay? You know, the Medicare guidelines are very clear about this. This is not from the JMPT article. This is actually from an excerpt from one of the LCDs, or local coverage documents from Medicare. This one specifically is Novitas. But if you look at some of the wording within the LCD, it says at the very bottom that Medicare requires medical necessity for each service reported to be clearly demonstrated in the patient's medical record, obviously. Medicare expects that patients will not routinely require the maximum allowable number of services. Okay? And you know what? What Medicare is saying there is, for instance, this LCD that Novitas puts out gives some pretty clear treatment parameters. One of them is the utilization guidelines for the patients are 12 visits per month and no more than 30 visits per year. Well, you know, we notoriously will do that. We'll notoriously treat the patient up to 30 visits because we can get 30 visits, and that's what I'll hear doctors say all the time is, well, I can get 30 visits from Medicare. Well, that doesn't mean anything. What you need to do is you need to look at those 30 visits and look at that as, how am I going to manage this patient's case? Maybe this patient will need that full 12 visits if they're coming in with an acute low back problem, but maybe the remaining 12 visits are going to be for management of chronic care, or as we do a trial of withdrawal from care and start spreading out those visits a little bit more to see where that patient's threshold is, to see if the patient is truly a chronic patient or if we need to move them into supportive care. And so, Medicare is clearly telling us that they don't expect you or expect that the patient is going to need all 30 visits. And subsequently, insurance carriers follow the same guidelines. They will say, yeah, a patient has so many visits, but that doesn't mean we're going to improve that many. United Healthcare, for those of you who are in network with United Healthcare, is a perfect example of this. If you look at a patient's policy within United Healthcare, you will see that maybe the policy tells the patient they get 20 visits per calendar year. Okay. However, those visits have to be pre-authorized through a third-party administrator, Optum Health. And Optum Health will give maybe 6 to 8 visits at a time, because what they want to see is they want to see the documentation that shows that additional visits would be reasonable and necessary. And so there's this constant struggle between what a patient sees on their plan versus how many visits are actually being authorized based on the documentation that you are sending in to the insurance carriers and the supporting evidence for the necessity of that care. So again, I really want everybody who's on this call, and if you receive this we're going to be recording this, and I'll be sending this recording to the clients who weren't able to attend this call. I really want you to be able to look at this and realize that just because it says you get so many visits does not mean that you get so many visits. Okay. Is my voice cutting in and out? Hold on a second. Somebody just texted me and said my voice was cutting in and out. Let me pull up the chat. If you're having problems hearing my voice, please put a note in the chat feature letting me know that you're having issues. Okay. So let's talk about some of these best practices that the CCGPP has discussed within this article. Okay, one is therapy to rehab, and again, as I'm looking at my clients, and this is what I did when I read this article. I started thinking about my clients in general, and obviously not all of you are guilty of this, but some of you are. Some of you are guilty, for instance, of the adjustment to therapies, adjustment stim and traction forever. And you perform adjustment and stim on every patient encounter. Instead of moving toward the best practice of an initial course of chiropractic treatment, which they feel the CCGPP includes one or more passive, non-exercise manual therapeutic procedures, which is appropriate and best practice for the initial course of chiropractic treatment, okay, and physiotherapeutic modalities for pain reduction, such as ultrasound, okay, or heat. In addition to patient education designed to reassure and instill optimal strategies for independent management. So while that initial course of care is taking place, you need to be educating your patient on how they can prevent this from happening again. Now it says, though, although the evidence review does not generally support the use of modalities, ultrasound, e-stim, in isolation, their use as part of a passive to active care multimodal approach to low back pain management may be warranted based on clinician judgment and patient preferences. We've heard this for a long time, and it's in writing. It's telling us that passive therapy has its place, but in very, very limited situations, okay? And it is also saying that what insurance carriers are looking at, what best practices are being defined as, is a movement towards away from the passive modalities and then into active rehab. Okay. Also, be aware that under the best practice under the CCGPP guidelines, lumbar supports, bracing, taping, orthoses are not recommended for routine use, okay? And that just means that it's not something you would do with everybody. So, I mean, I actually had a client at one time who did on every new patient on their low back and also thoracic, did kinesiotaping. And is kinesiotaping appropriate every single time? I don't think so, you know, and I think it was done as a way to generate more income. All right. And practice management companies are notorious about that, about talking to you about income streams. But what they fail to do very often is temper that with the scientific guidelines that are out there for you as chiropractors that give legitimacy and credence to the therapies that you are giving your patients. Okay? Caution must be exercised as these orthopedic devices may interfere with conditioning and return to regular activities of daily living or ADLs. Okay? And so, it goes on to say that although passive care methods for pain or discomfort may be initially emphasized, active, i.e. exercise, care should be increasingly integrated to increase function and return the patient to regular activities. And then, of course, going back to Table 3, lists appropriate frequency and duration ranges for trials of chiropractic treatment for different stages of low back pain. Another best practice that's discussed in the CCGPP guidelines is reevaluation and reexamination. This is an area where I think as a whole, as a profession, we fall tremendously short. After an initial course of treatment has been concluded, a detailed or focused reevaluation should be performed. The purpose of this reevaluation is to determine whether the patient has made clinically meaningful improvement. A determination of the necessity for additional treatment should be based on the response to the initial trial of care and likelihood that additional gains can be achieved. So, if you are part of a management company, for example, or part of a group that says, get your patient scheduled for a year's worth of care or have them pay for a year's worth of care, this completely contradicts that. Okay? This completely contradicts scheduling a patient for 30 visits up front. Okay? What you would do under a best practice would be to look at that case as acute, subacute, chronic exacerbation, base your treatment parameters on Table 3 for all intents and purposes, the guidelines within Table 3, which give you a range of visits, and it gives you a period at which you would reevaluate or reexamine that patient. Once you have completed that reevaluation and reexamination, that would be the time when it would be appropriate for you to schedule more visits. Now, I know, and guys, I'm sorry about this. I know that some of you are probably listening to this and scratching your head because in the past, many years ago, I would have told you differently because I was a practice manager. I was part of a practice management group. And so I was trained to give treatment recommendations to chiropractors that were based nothing except, these Mercy Conference guidelines that just gave numbers of visits. And so, what I'm telling you is that this is not going to be the appropriate response based on best practice. As patients begin to plateau in their response to treatment, and this is another best practice, is how to handle the patient who has plateaued or who has reached MMI, maximum medical improvement, or what they call MTB, which is maximum therapeutic benefit. As patients begin to plateau in their response to treatment, further care should be tapered or discontinued depending on the presentation, not depending on specific numbers of visits. A reevaluation Another exam is recommended to confirm that the condition has reached a clinical plateau or has resolved. So at the point at which you are going to begin to either wean this patient off care, okay, or at where you are going to release them to supportive care, it should conclude, bookend. At the beginning, you start with an exam, and at the end, you end with an exam. When a patient reaches complete or partial resolution of their condition and all reasonable treatment and diagnostic studies have been provided, then this should be considered a final plateau, maximum therapeutic benefit, MTB or MMI. The DC should perform a final exam, typically following a trial of what they call therapeutic withdrawal, meaning we take the visits and we begin to spread them out to verify that MTB has been achieved and provide any necessary patient education and instructions in effective future self-management and or the possible need for future chiropractic care to retain the benefits achieved. Okay? Does this mean the patient never comes back? No. They may come back under supportive care. Supportive care, however, is not covered by insurance, and the patients need to be made aware of that. However, if a trial of therapeutic withdrawal is conducted properly and it's determined that this patient has a chronic condition, then maybe if the patient hasn't maxed out their benefits, that it may be that additional care would be paid for, but your documentation would have to show that and would have to prove that you have conducted your case management in a way that proves the existence of a chronic condition. If the criteria, here's another best practice, reducing medical and provider dependence. Now this is huge right now. We are seeing more and more insurance plans. We're seeing more and more best practice treatments. And by the way, you know, I have the privilege of not just doing billing and education for chiropractors, but I'm out teaching at hospitals. Okay, I'm teaching cardiologists these same types of best practices. I'm teaching physical therapists and and other medical disciplines. And we are not alone in this. There are many medical disciplines that are being guided into these scientific approaches and these best practice models. So, and one of the things that is being clearly taught throughout the medical profession right now is to get patients to reduce their dependence on medical and provider dependence, on drugs and on provider dependence. If the criteria, and what the CCGPP article says is, if the criteria to support continuing chiropractic care have been achieved, a follow-up course of treatment may be indicated. However, one of the goals of any treatment plan should be to reduce the frequency of treatments to the point where MTB, maximum therapeutic benefit, continues to be achieved while encouraging more active cell therapy, such as independent strengthening and range of motion exercises and rehabilitative exercises. I listened to this was several years, actually it was many years ago, probably 10 years ago. I listened to a webinar by Kim Christensen, and he was one of the kind of forerunners of chiropractic rehab. And one of the things he discussed that I thought was awesome was doing a mini treatment rehab plan with patients in the office, where the patient is given home exercise instruction, guided home exercise instruction for about 3 to 6 visits, and then they would purchase a home exercise kit, consisting of a gym ball and some TheraBands, and a foam roller and some other small items, maybe low weight hand weights that they could use. They're taught to use them in the office, and then they're sent home with those for ongoing self-care. which helps them develop good, effective habits that they can employ for a lifetime. And then the patient would come back into the office once a month to have their progress monitored. I thought that was a great way to manage that, that patient's treatment, and it falls in line with what the CCGP guidelines are saying here. Okay. Patients also need to be encouraged to return to usual activity levels, as well as to avoid catastrophizing and overdependence on physicians, including DCs. We love our patients and we love having them come back, all the time, month after month and year after year. But even your chronic patients, you have to decide whether these patients are truly chronic patients or if they're coming in for supportive care. Okay, there's a big difference. And if they are truly coming in for supportive care, you have got to wean them off of the dependence of their insurance. Okay, and possibly you'll find that these patients will no longer want to come in, and at that point you would want to give them some good education on self-care and home care so that they do not end up deteriorating over the years into a chronic situation. Okay, so one of the things that you definitely want to look at is how you are discussing with your patients what they do from an environmental standpoint and from a self-care standpoint to prevent problems from reoccurring. Another best practice is how we manage exacerbations and chronic conditions. When a patient's condition reaches a plateau or no longer shows ongoing improvement from the therapy, a decision at that point, doctors, must be made on whether the patient will need to continue treatment. Generally, progressive longer trials of therapeutic withdrawal may be useful in ascertaining whether therapeutic gains can be maintained without treatment. Okay? Now, in a case where a patient reaches a clinical plateau in their recovery and has been provided a reasonable trial of interdisciplinary treatments, additional chiropractic care may be indicated in cases of an exacerbation or a flare-up, or when withdrawal of care results in substantial, measurable decline in functional or work status. Okay? Always think function when you're dealing with that chronic patient. It's not as much about pain as it is function. Okay? Additional chiropractic care may be indicated in cases of exacerbation flare-up in patients who have previously reached MTB if criteria to support such care has been established. Another best practice, and this is one that, again, I see a great lack in the chiropractic profession, is the use of proven outcome measurements. For a trial of care to be considered beneficial, it has to be substantiated, meaning that a definite improvement in the patient's functional capacity has occurred. Examples of measurable outcomes and activities of daily living and employment may include, and they're not just limited to this, but these are actually proven outcome measurements that you can use within your documentation to lend meat to your conclusion that this patient needs ongoing chronic care. Pain scales, such as the visual analog scale and the numeric rating scale, pain diagrams that allow the patient to demonstrate the location and character of their symptoms, validated ADL measures, such as the revised Oswestry Back Disability Index, Roland Morris, RAND 36, and Bournemouth Disability Questionnaires, increases in home and leisure activities documented in your documentation, in addition to increases in exercise capacity, increases in work capacity, or decreases in prior work restrictions, and improvement in validated functional capacity testing, such as lifting capacity, strength, flexibility, and endurance. These are all of the things that you would want to look at documenting within your clinical records to show that a patient who has a chronic problem is receiving therapeutic benefit as a result of chiropractic care. Another best practice for us, and this is just something to be aware of. I know that as clinicians, you all do this, but I also know that we can get into ruts, both mental and physical, and just, essentially we're just going to get into a routine of treating patients and get into ruts. And this is especially so with established patients that we have seen over a long, long period of time. We may not even realize a patient's decline depending on how often they're coming in. We don't see it. But these are things that you need to be aware of and alert of all the time, which would be contraindications to chiropractic care. So if you are aware of these types of situations, this is where chiropractic would be contraindicated. All right, and you would immediately want to refer that patient out to the appropriate healthcare delivery system to possibly do further testing or to treat that type of a condition. So I'm not going to go through all of these, but these are for your reference. Keep these in mind. You may go out in the next week or so, and just as a result of listening to this webinar, come across a patient who has one of these conditions that you may not have even, you may have just blown through that patient treatment and not realize that something else is going on with that patient that would contraindicate the treatment for that day. Okay. Generally, procedure or therapy is contraindicated over relevant anatomy and not necessarily contraindicated in other areas. Sometimes certain conditions may be contraindicated. So, for example, you would not do low back manipulation on a patient who has had a surgery within a certain number of months, okay? But you could still manipulate the cervical spine, okay? It doesn't mean that you don't treat the patient at all. You may want to avoid certain anatomical regions of the spine, though, depending on some of these types of conditions, okay? Other conditions that may require co-management, okay? In other words, where you and the patient's primary care physician or their specialist would want to get together and make sure you are correctly co-managing that patient, would be if you are treating a patient for cancer pain or post-op surgical pain. And then also know when to refer. Understand when it is appropriate or not appropriate to refer your patients out, okay? So, how this affects you. The scientific approach to patient case management, number one, if you are utilizing this approach, it's going to give you credibility within the medical profession. The traditional chiropractic approach, in which a trial of natural and less invasive methods precedes aggressive therapies, has gained credibility. However, the chiropractic profession can gain wider acceptance in the role as the first point of contact or the first responder, so to speak, healthcare provider to patients with low back disorders, particularly within integrated healthcare delivery systems, by embracing this scientific approach to evidence-based healthcare. We talked about this in the earlier slide. Doctors of chiropractic can use methods that assist patients in self-management, such as exercise, diet, and lifestyle modification to improve outcomes and their stabilization to avoid dependency on healthcare system resources, okay? And chiropractors also recognize that a variety of healthcare providers play a critical role in the treatment and recovery process of patients at various stages, and that DCs should consult, refer patients, and co-manage patients with them when it's in the patient's best interest. So let me ask you this question. How is your relationship with your local medical establishment? Are you able to fulfill this best practice within your community? Scientific approach also gives you credibility with your patients. It provides you a structure and shape to a treatment plan. The structure and shape would be the consultation, the examination, informed consent, report of findings, treatment and treatment goals, re-exams, and providing that patient a course of withdrawal, a trial of withdrawal care, in other words, spreading out those visits, and then finally a release of patient to supportive care or a determination that that patient is a chronic patient that will continue to need ongoing treatment. Scientific approaches to patient case management gives you the credibility to charge a patient fairly for what you do. Okay? I know that sometimes my clients, and I have had this with when I was a practice consultant, is that they're afraid to charge patients for their services. But I guarantee you, if you are you are providing a scientific approach to this, it's going to be much easier for you to look that patient in the eye, to have your staff look that patient in the eye and collect that money for that service, because it is extremely pertinent and valid. Scientific approaches to patient case management give you credibility with the insurance carriers. You know, within the next 2 years, we are going to be moving to a value-based, we're already moving into a value-based model and a merit-based reimbursement model versus a fee-for-service model. All of this is designed to move us into a model in which those healthcare practitioners who are utilizing best practices are rewarded for basically for their good behavior and for utilizing these scientific approaches to case management. And that is a whole other webinar in and of itself, is how this new payment model is going to be taking place within these next 2 to 5 years. So finally, in conclusion, I want you to ask yourself these questions, and I'll go through just a few of these, but this is kind of a self-test for yourself. Ask yourself, am I diagnosing or treating patients based on the science or based on what I think insurance carriers want or what the patients want? Number 2, am I guilty of using the same diagnosis code sequence on the majority of my patients? Do I use it? I mean, I understand that with Medicare, we have to start with M99.01 for most of us. Now, some of us, it's not the case, Florida, Kansas, but you know, for most of us, Medicare LCD says we have to have M99.01 through 05 as our first diagnosis code. Okay, that's fine. But what I'm saying is, you know, what about the other diagnosis codes? We see this all the time as billers. I'm telling you. We see, you know, M99 followed by low back pain, followed by M99, followed by thoracic pain, followed by M99, followed by cervical pain. And then we see our doctors trying to treat patients 30 times with that diagnosis sequence. Okay? Do I look at my diagnosis codes at each visit and review whether they are still appropriate for the patient's treatment that day? You know, if I have, you know, 6 diagnosis codes on my last visit, and today I'm just going to be manipulating the C-spine, but I still have lumbar and thoracic representative, I need to take those off. Okay, am I checking that at every visit? Do I have a good understanding as to when I should evaluate and reevaluate my patients or re-examine my patients? Do I have a good understanding of when it's appropriate to use passive modalities versus active rehab? Do I explain clearly and concisely a patient's condition to them and give them not only a treatment plan, but explain the goals for treatment to them? And do I provide their plan and their treatment in writing? Okay? Do I give written and verbal informed consent? This is an area where I see a lot of doctors lack. They do not give written and verbal informed consent. Do I have a bulletproof documentation system in place to prove my science? Do I inappropriately use X-ray as a diagnostic tool for nonspecific low back pain? Do I have a clear understanding of E&M coding guidelines? Do I have a good grasp on utilization guidelines based on the patient's presentation? Do I understand the differences between acute, subacute, chronic, and exacerbation? Do I routinely look at my CPT codes that I'm billing for to see if they're still appropriate for the patient's stage of care? Do I understand when it is appropriate to begin a trial of withdrawal from care and move the patient to supportive care? Do I feel comfortable charging patients for services that may be necessary but not covered by an insurance carrier? Do I have a good relationship with members of the medical community? Do they even know I exist? Do members of the medical community look to me as a first responder for case management and treatment of non-specific low back pain? Do I routinely provide written updates to my patients' uh, primary care providers? Do I have a clear understanding of when it's appropriate to refer a patient out for care? And do I engage with the patient and encourage them to co-manage their condition with home exercise, diet if warranted, and environmental lifestyle changes? You I know it's a hard thing sometimes for us to talk about. We have a patient come in that's 5'6", and they're 225 pounds, and they have chronic low back pain. Well, do we talk to them about their weight and about getting on some kind of a weight management plan? I mean, sometimes I think we think that's politically incorrect to do that, but we're doctors. And so if that is a factor in their low back condition, it needs to be addressed and it needs to be discussed seriously as a chiropractor. It doesn't mean that you have to provide that treatment or that therapy to the patient, but you should be guiding them and at least advising them that their low back condition would probably resolve tremendously if they were to make a commitment to lose 60 or 70 pounds. Okay? Don't be afraid to do that. So please take that questionnaire that I just gave you, those little questions, and do a self-assessment. See where you feel you may need some help, some guidance, and if you need to talk to me, if I can point you to another expert within the chiropractic industry who can help you with your new patient, established patient case management. Obviously, I am not a chiropractor, so the technical aspect of the different exams that you should be doing and so on and so forth are outside of my scope. But I do know what should be contained in a well-documented treatment plan for patients. And please understand that, many of these concepts that I talked about, although they are within the paper for low back pain, would also apply to other conditions, okay? The treatment parameters may change depending on the condition, and of course you can look at the CCGPP guidelines for cervical conditions and so on and so forth as well, but the basic tenets remain the same. Okay, we're finished with the presentation. What I'm going to do now is I'm going to pull everybody off of mute. If you're not speaking though, I would ask you to go ahead and mute yourselves because there's going to be a lot of background noise. So do we have any questions or concerns that you would like to bring to the table at this point?
Mm-hmm.
Anybody? Okay. So we will.
¿Ya te enojaste?